Our group is going to be talking about the peaceful end of life and theory of comfort care. This is a middle range theory. And what are some main points that you guys found of this theory?
For me and Kaba and Fisher, 1996. I don't think I pronounced that right, but basically, I think both those authors kind of highlighted the theory that for comfort care in the healthcare system, it's not as integrated right now, just because of confusion around like what comfort care means. And another, like, just going with that, just highlighting the point that, like, when comfort care is implemented for terminally ill patients, it can greatly enhance their quality of life, and is why it should be something that's introduced for patients who are terminally ill.
Yeah, I agree. And just piggybacking off that, in the Kolkaba and Fisher 1996 article, they gave the two different case studies. And I think what really stood out to those was the aspect of the nurse just being with and listening to the patient, because both of the patients ended up having like a quote unquote peaceful death, and they got like the wishes that they wanted, but they were also tremendously different between the two of them. And so it just like shows the individualization of like the theory of a peaceful end. It just depends on the patient.
Yeah, it's super important to keep those goals in mind, especially when it comes to talking about ethics and everything. And those theory can be applied to anyone nearing the end of their life. What patient group would you guys like to use as an example when we're talking about how to create maybe an assessment tool?
I think the patient population we were going to focus on was those who are terminally ill, so patients with cancer, with poor prognosis.
Yeah, absolutely. Did any of you guys have an idea for an assessment tool that we could use that is maybe guided by this theory, but used to evaluate a patient's needs based on the philosophy of the theory?
Yeah, I kind of do. So, like, again, using the Kokaba and Fisher article, they gave the graph that assesses like the different types of comfort and the context in which the comfort occurs. So, you have like physical, psychospiritual, environmental, and social context, and then like relief, ease, and transcendence. And in order, like, if you help alleviate one, it should help alleviate all the other ones around it. But I feel like kind of using an assessment that identifies maybe the physical, psychospiritual, environmental, and social discomforts, and then like ways that perhaps they can be interventions can be implemented to alleviate those discomforts might be useful when we're trying to individualize this process.
I definitely agree. And as Sierra said, we would be using this assessment tool on cancer patients who are terminally ill and have a poor prognosis. But what do you guys think would be the best timing for when to kind of start asking these questions?
I think as early as possible is always better, just because you never want like a patient to be uncomfortable, and you want to, I think, in nursing, like, regardless, like, those aspects should be taken into consideration. And this is just kind of like a good graph to like um just like ensure the standard of care is being like upheld, and just make sure that the patient's like quality of life, you don't want like someone's quality of life to like go down before you're like, oh, should we implement comfort care now, sort of thing.
Yeah, and I think like we're able to accomplish all that using an assessment that like highlights like the five main criteria that Ruland and Moore 1998 established, which was like not being in pain, the experience of comfort, the experience of dignity and respect, being at peace, and closeness to significant others. I think like using an assessment that encompasses all those will like meet like the expectations, and we'll be able to like meet what the patient needs and like what Tara just described as well.
I think those are all super important points for ensuring the best quality of life possible. And again, since you mentioned people are so individual in their needs and struggles and wants, I think it's best to use open-ended questions and kind of an interview sort of setting rather than a close-ended questions or more of a survey or questionnaire that would close them in to only have a certain number of answer choices, and maybe be more exhausting for a patient who's terminally ill as well. But do you guys think it would be better to make a tool with more of a score or kind of a general assessment at the end of the survey?
So I think it might be useful to have like I don't know if a score or an assessment, but something concrete at the end. The reason why I think that is because I'm going to butcher this, but the Ngabonziza et al. 2021 article on like peaceful end of life theory indicates that while like it's super important for nurses to incorporate the peaceful end of life theory into their practice, that it's also really difficult to get like this like very specific outcome measurements. So it's hard to like figure out if we are actually meeting that peaceful end of life, seeing if they're actually satisfied, especially as they get to like end of life when perhaps they can't talk or they're very like critically ill. So I think like an assessment that has a definitive either value or a definitive like explanation at the end would be useful to use so that we can hopefully start gathering data, because that's part of like what a middle range theory is something that can be used empirically.
I definitely agree with that. I think that the scoring process will kind of be based on how they're evaluating their own progress in the various categories. For example, like the psychological category, we could ask questions about their spirituality and how comfortable they're feeling with the end of life process, etc. And the score would indicate how much support they need in that category, be that assistance from a chaplain or their own spiritual leaders, or things like therapy or a psychiatry intervention. Be super important. And how do you think we could teach other nurses on the floor about this theory and about how to complete this assessment?
I think a lot of it is going to be like kind of, I think you could teach like a lot of these theories, I think you could teach someone, but they're not going to really understand it until they go through it and like experience like someone at their end of life and like interacting with family members and the patient and stuff. So I think a lot of it is going to be like on the job training, like a short explanation of what's going on, and then like literally having them experience this and work with patients and see what works. And kind of like what you mentioned, Maya, like I think it's important to gauge the patient to see how they're doing. But Rowland and Moore 1998 also says like it's just as important to like survey family members and spouses, because like I said, when the patient is, if they can't talk, if they can't move, it's important to talk to like the people who know them best to see if, are they comfortable? Is this how they are at home when they're comfortable? And that'll be a way to gauge that. And so like I said, just circling back, I think kind of thrusting nurses into this role of having to do it is going to be the best way of like having them learn how to navigate these sensitive topics.
Yeah, I definitely. Oh, sorry.
I was just gonna go off what Alistair said. So, from also I can't remember the Rowland and Moore 1998 article. There was like a box number 1 that talked about like outcome criteria for that standard of peaceful end of life. And I think like just making like as a new nurse and learning about it, like making notes maybe off of that box, like is the patient not having pain? Are they like are they at peace with everything? Making sure they're not dying alone, like if they wish to have someone there, like just having the nurse understand that like these are questions that should be like running through their head, and that might like help them grasp the like learning the theory and the assessment tool a little bit better by like going off questions that are a little bit easier and can like pertain to patient care rather than like abstract, if that makes sense.
Yeah, just like they discussed in Fawcett 2005, mid-range theories of nursing are super necessary for the advancement of the nursing field, and it might seem like they're really abstract and easy to dismiss, but once in practice, they're definitely very useful and necessary tools. So yeah, lastly, I just wanted to hear some of your reflections. I feel like this was a really useful discussion. I feel like we've made a lot of progress in developing an assessment tool potentially that could be used to evaluate people at the end of life, their needs. And I think it would be awesome if we could tack on to sort of follow up every month with the patient to see if their needs are changing. But how do you guys feel about what we've talked about so far?
I think from just like what we've talked about in general, I think for like our assessment tool, a good point, like reflection point would be like how teamwork could be implemented into it, just because a lot of the things we talked about, like could really benefit like the help of social workers and case managers and like nurse managers and like floor nurses, like all working together to implement that, and like the role that like nurses could have and like advocating for themselves and their patients to have like review of patient care and like quality of life sort of thing. Just like the role that nurses could take in the hospital and clinical setting.
Yeah, I agree with Tara. I think like another really important topic that it was kind of mentioned in, let's see which article it was. In the Kolkaba and Fisher article was like they mentioned how one of the patients had like a favorite nurse and they really wanted that nurse to like be there with them at the end of life. So I think like you said, like talking among nurses, not just about like what to do, but like as they're transitioning care, like at shift change, making sure that part of report is like the patient's preferences, what the plan is, and like how they're gonna like hopefully get that peaceful transition of life. And then also like if possible, coordinating with management to ensure that if and when that time comes, if they're able to have their favorite nurse or their favorite provider there, just doing whatever possible to help that peaceful transition into end of life.
Well, great reflection. I think that raised a lot of really important things to discuss in the future, and I think we've got a really great potential tool here.